talk, if the title of it, you recording, Nigel?
Yep.
Oh, spot on. So yeah, if the title of the talk's an unusual one, I think that's entirely reasonable, given that it was for myself when I encountered these patients along with my colleagues in our department. So they're all real cases, all presented to our PZD within the last 18 months, to be honest, or maybe some of them a bit longer, and all written exactly how it occurred in the notes. And hopefully we find them interesting. So I think the theme of the talk really is to look closely. So on first glance, you sort of see, and I wish I could dress like this at work, scanning a child. But when you look more closely, you might see things that you didn't expect, Got stethoscope in, we've got an unconnected ultrasound probe scanning on the skin. And then sometimes things get really unusual and weird. So I think you've got to keep a high index of suspicion. I don't know what I would be doing here, kind of safeguarding endocrine follow-up or something unusual. But a lot of these cases were slightly similar. Because when you see things, you may doubt yourself. This was a photograph on my elective, not taken by me. But unfortunately, sometimes things are just as unusual as you expect. So the background to this would be that children will present to the PEDD with cancer, right? And around about 55% of them, based on the latest data, will they receive the diagnosis in the PEDD, but unfortunately, fairly often that will be after repeat presentations whereby things have ultimately been missed. And the background to that, we all know as pediatricians, is that children, for many reasons, are difficult to diagnose with the correct thing. A lot of the time we're going to be seeing high frequency, low risk kind of events that aren't concerning. Bacterial or viral is sometimes the biggest concern we have to worry about. But actually, there can be children of all ages, as we'll see in this talk, from 3 months, 2 months, right the way up to 20, 18 to 20, depending on what department you work in around the world, where they will present with unusual things. And I guess it's our duty to try and pick things up readily if we can. So as you know, I'm a big advocate of POCUS as an extension of clinical exam. And I think in all of these cases, this helped me to narrow in and make hopefully a correct diagnosis. So this is the paper that we've just had published that includes the cases in this talk, if you want to go and have a look. And the first one is this lovely little girl who her family shares her story with full consent. So you'll see a picture and some dates and things. And she presented on a Saturday afternoon. Just going to check to see who's on the call, see if the people who are involved were in. Going to credit everybody who was involved, but no, we don't have the person involved there. But this little girl presented to our department, and she had slight kind of redness or puffiness to the right eye, and had been back and forth to various places, including pharmacy and GP, to treat for potential sty with hot water baths, that sort of thing. And I looked at her, and I didn't see a sty. I saw this eye, and what I noticed was possibly just this very, very, very slight asymmetry, which was a bit unusual, but was very, very minimal. So I did what some of us might do, certainly what I would do, which is to add a bit more detail using POCUS, because we can't infer a great deal else other than, this isn't periorbital cellulitis, orbital cellulitis, there's no sty. What's going on? What are these symptoms? Are they infective? Are they not? So I used POCUS. I did an ocular POCUS, which is dead easy, quick, easy tolerated to do. And I guess I was looking for any ocular cause, or for, our normal thing we look at, which is optic nerve sheath diameter, looking back here. I don't know if anyone on the call does a lot of ocular POCUS, but when I put the probe on, I was immediately pretty devastated that I found something quite nasty here, because all of this tissue in the retroorbital space, all of this thing here, this heterogeneous stuff just should not be there. That's not normally present. And I guess in context, I probably thought that I was dealing with something quite worrying. So Saturday afternoon, I spoke to the eye infirmary. We talked a bit about visual acuity. We talked a bit about what would be the best next test. And they obviously recommended cross-sectional imaging, which we knew we needed to get. And I had a real job trying to kind of convince various people as to what we needed to do, which was probably to get an MR. And hopefully this child would lie still, and hopefully we'd have someone to report it in context. But even between neurosurgeons and ophthalmologists and radiologists, a lot of the time I was sort of getting an answer of kind of, I don't really know how to help you here. I don't know what these findings sort of mean. And that was including after the MR. So anyway, we got the MR, and this is what it showed in the sort of right retroorbital space. This kind of nasty looking lesion. And we got eventually someone to report it. A neurosurgeon said, no, this isn't us. You need to speak to oncology. And I got a really helpful, really supportive oncologist who was able to assist, who looked at this straight away and said, this is a rhabdomyosarcoma. I've kept all of this information here just for context. Obviously, again, the dates and stuff are shared with full consent. So following transfer at the tertiary centre, this child had some imaging, various imaging, and this was a diagnosis of rhabdomyosarcoma, which is obviously a highly aggressive cancer, and sometimes picked up very late within, connective tissue and muscle, and can sometimes obviously be fatal. However, I think in this case, we were able to pick this up fairly quickly. So actually, the discussion I was received from the oncology team was, you can tell this girl, we'll treat this, tell the family we expect her to keep her sight and she will survive. That's literally what he told me over the phone, which was really powerful, I think. So yeah, we know this is a kind of a rare malignancy of undifferentiated mesenchymal cells, which can be connective tissue or eventually muscle, and there are different types. I spoke to the family most recently yesterday, and she is doing amazing. She had proton beam therapy and some chemotherapy, and effectively she looks to be heading into remission at present, which is amazing. So the next girl, I think, was the only case out of the 7 or 8 that wasn't my scan. So this was a 2-year-old girl who had a lump on her head, and she had walked into the edge of a door 11 days ago at nursery, and it was one of these traumas that we all see as paediatricians, whereby it's a trivial trauma that's attributed to the end event. You know that doesn't really mean anything. We had a child with back pain who was having 6 weeks of back pain. They're only about 7-year-old, and they'd slipped on a puddle in school one day, and you just know that's completely irrelevant. Unfortunately, with something like persistent back pain, actually, we're probably dealing with something more concerning. And this was a similar case here. So this girl had a really large, significant swelling, I think, on the left side of her head. And I was on a beach in Spain when one of my consultant colleagues asked me to look at a scan that he'd taken. So this was her examination, which was fairly unremarkable. And again, this girl had been seen 3 times in the urgent treatment centre in the past sort of week or so. And this was our scan. Now, I'm sorry, this was coincided with the time when our machine had to go off and be serviced, so we lost all of our images. So this is a photograph of the POCUS, as you can see. And we can see the skull. We can see that kind of hypoechoic line here with a really significant lesion or gap in between. On one hand, you might buy this as a depressed skull fracture, but it's not like any of the ones that I've seen. It looks very uniform. There's obviously this big sort of thing around it that I guess you certainly would buy as a hematoma or some soft tissue sort of event, swelling. But yeah, we were discussing, and I sort of said, that I think we obviously going to need to image, but this doesn't really look like the skull fractures we've seen, and it would be unusual with the story. This would be more what a skull fracture looks like. We've obviously made this diagnosis a few times in the PED using POCUS, with the ragged edges, the oblique sort of bony edges, often with some surrounding fresh blood, hematoma we can see here. And this was the girl's CT, large swelling and defect in the bone. And there were multiple differentials provided at this point in time, which were, sorry, I don't know if there was a chat. All good from the chat? That's fine.
Yeah, there's just a comment from your last case from Antonio saying it was a good catch. But
oh, thanks, Antonio. Yeah, just jump in if you need to, Nigel. No problem. I'm in mode, so I can't see it. So yeah, there were various differentials put forward based on the CT, potentially a metastatic process or an eosinophilic granuloma. And this girl was again transferred to the tertiary oncology site, which is not our PZD. And the eventual diagnosis was of Langerhans cell histiocytosis. And this, again, is quite a rare pediatric diagnosis. It's something we do see. I've maybe seen 2 or 3. and that's kind of described as a cancer. It's an inflammatory kind of neoplasm of myeloid dendritic cells, so like macrophages. And so I'm glad no oncologists are on the call, because it's a POCUS talk. But yeah, it can affect different sites at different peaks in age. But overall, is kind of quite rare, commoner in children than in adults, interestingly. And again, having touched base with the child's family, she's received some treatment and is actually doing very well. And I think, the earlier it's sort of known about and treated, the better. So that was quite an interesting turn of events, but one in which, a lot of the focus was on hematoma, because effectively what she had looked like a hematoma. So again, POCUS helped to kind of expand the kind of differential, I guess, and give us a bit more information. This next little boy came in late one evening to the PTD midweek. He's 7 months old, and he'd been described as basically possibly losing weight as well as not gaining weight very well. So he dropped through some centile spaces, and when he came in, he was quite pale, and not kind of really anemic white pale. He just didn't kind of look right. I don't think he was anemic in the end, but there was something that just didn't quite look right. And he had quite a full little abdomen relative to the rest of his sort of body. And probably what I thought was some fullness. So it didn't look like a great story. Subsequently, we looked back, and he had, as we got him transferred, his blood pressures were very high. So I put the probe on, and I had a look, curvilinear. So on one first glance, if you were looking at this from the end of a room, you might go, okay, we've got a liver or a spleen. But actually, you look much closer and you think, not a chance. That's on the left. So for one, it's not a liver. And anyone who does any abdominal scanning, you look closely, you can just tell this is an extremely heterogeneous lesion. It's not what we expect to see. And also, of course, there's no kidney. So with the high frequency probe, looking again a bit closer, this is a really kind of nasty appearance. I don't like the look of anything like this. Very sort of, in my terms anyway, very heterogeneous compared to what I'd expect for a standard sort of organ, viscera, possibly some central areas of calcification and some darker areas as well. So I was worried that this was something really bad, given the story. And we had a discussion with the oncology team, who he said, well, probably what you're seeing is a new neuroblastoma, because I think at the time he said they'd had 2 or 3 new referrals in the last fortnight. So the lad went across. We didn't do anything for his BP there, and then we just got him across. He was actually quite well. And this is what a CT abdo showed. An extremely large mass from the left side of the kidney, extension across the midline, displacing the vessels with mass effect, and that was most likely a Wilms. And I think if you look back, you can see that sort of there's no renal tissue that you can really see at all on the scan anywhere. You can just kind of make out, you can, I think at one point I almost thought I could see a little bit of sort of kidney somewhere, but it's again kind of a fairly worrying tumor to pick up. This was his growth chart. I looked back, just these were different attendances at different times, obviously kind of, some of them a few months back, so whether or not this was relevant, but actually we can see we certainly would drop through centiles. And the thing I always look at with weight is just the weight gain. I'm less, in context, I guess I'm less worried about centiles per se, but I'd want to look at this one, and this one, see if there's much of a change between then and then, of which there was not a lot. So this young man had some chemotherapy followed by a nephrectomy, and he's doing brilliant. He's in full remission, and he actually presented to the department a couple of weeks ago with something totally unrelated, and is doing great. This was a 15-year-old boy who presented to our trauma clinic, and I can't remember exactly how he ended up in the clinic. I think it was from an urgent treatment centre again, with a lump on the chest that was sore, possibly trauma related. And just getting something from the chat, but just yeah, he had a sort of a firm lump on the left side of his chest at the sort of the sternoclavicular region. It was painless, but it was causing him a bit of difficulty when he was laid down at night. It certainly wasn't red or tender, and it had enlarged. And when we checked, there hadn't really been any significant trauma, although he was a rugby player. So my colleague, the background was that he was totally well, not a great deal else to find. The lump was about 2.5 centimeters by 2.5. And can't remember what came first, whether it was the x-rays or me asking to scan, but these were his x-rays, and the lesion was sort of in this area. So you can see it's completely unremarkable. And this was a really, really quite a big lump, as you'll see next. So my colleagues, another consultant colleague who does a little bit of scanning, she just said, did I want to come and have a look? And because the x-rays were not helpful. So put the probe on. This is what I've found, this very unusual thing. And I think with POCUS, when you're expanding your repertoire, you will find things that you don't always recognize. As long as you have kind of, good governance systems in place and a plan for how you're going to integrate your findings, either get definitive radiology ultrasound, get definitive cross-sectional imaging, that's absolutely fine. That is fine because POCUS is an extension of our exam. It only adds more information. As long as we're practicing within our remit, I think that's completely fine to not always recognize what you see. And I didn't recognize this. I could see that I was above the pleura. I was within the sort of connective tissue with some overlying muscle. This was the medial end here on this side of the sternoclavicular junction. And it looked kind of hyperechoic. This is obviously kind of end of clavicle or the junction here. So it looked within the bone, but obviously the darker areas, the kind of anechoic regions, would normally be suggestive of fluid. So I wondered, could this be something like a lymphangioma, like a cystic hygroma, given that it's up in the upper chest, head and neck? But it wasn't like any I'd seen before. It looked more disorganized. So I thought it was probably kind of, within bone, but unusual it wasn't shown on the x-ray. So again, I took the machine round and showed the navigating radiologist and said, I don't know what I'm finding, but it's an unusual lump. It's a big lump clinically. Can we image? And we did. And it was a CT. And this was the lesion that we found in the sort of, again, that sort of sternoclavicular region. The rest of the CT was unremarkable. And this child again was sent into the adult kind of mixed orthopedic and oncology service, and it was later diagnosed as a giant cell tumor. So this is a tumor of bone, typically originating at the ends of long bone. It is a rare tumor, and it's composed of these kind of multinucleated giant cells. You may have seen these on X-ray. It's at the distal radius or the distal femur, and you see these sort of strange things. They're very kind of aggressive locally, but they're not metastatic or kind of malignant as such. And the treatment is surgical excision, which is what this young man had. They then debulked it, and then the plan is to follow it up with sclerotherapy. And again, I touched base with the family yesterday just to double check how he's getting on. He's waiting the sclerotherapy, but otherwise doing really well. Any questions about any of that case or any of the other cases so far? If there are, just feel free to chip in. So again, this young man's doing really well. This was a 5-month-old girl, and this was a little while ago, who had a lump to the left side of her neck. And this was the lump. The child was otherwise doing everything nicely, no concerns with feeding, breathing. But as is often the case, as you'll hear with families, they described that they did not see this lesion yesterday. This was not here. This, yesterday, sent it to nursery, and here it is. Her background was irrelevant. So again, I was quite concerned by the size of this lump and the region. It felt very large compared to most things that I would find in this age group, with a few obvious differentials running through our head. Anyone got any potential differentials? If you have, stick them in the chat, shout them out. So what I noted was a very large kind of 5 centimeter by 5 centimeter swelling, which is something I would not normally call it that big, but it was that big. And I think the team who were initially, maybe one of the resident doctors that initially assessed her, had cracked on and done some bloods, which weren't particularly exciting, possibly sort of borderline white count for that age. And they asked would I have a little look, and this is what I found when I scanned. So again, the sort of a lesion that doesn't resemble, given that in the region here we've got probably what looks like a normal lymph node just above, something very, very large, that if this was potentially a lymph node, it's certainly not a normal one by any stretch of the imagination. It's very rounded, so it's the kind of long to short axis ratio is roughly 1:1, which is definitely what you do not want. Clinically, it didn't seem inflammatory in terms of potential sort of abscess formation. So if you've got a early abscess formation from a lymphadenitis or a lymph node, given these hypoechoic, anechoic regions, that might be reasonable. But again, it looked a little bit more too heterogeneous from my point of view. So I knew that it was a worry, and I knew we needed a formal scan, given it was very large. Also, it was in quite an unusual sort of area, kind of level 5 area, kind of just above sort of supraclavicular region, lower posterior triangle, which is not great for stuff generally. I'm sure you'll agree. Yeah, level 5B. Even on this view, this just looks not nice. I'm sure a couple of people will agree. Antonio, I'm sure you probably agree. It just doesn't look great. So I sometimes try and pretend that I know what I'm talking about with these neck levels, and it's nice to communicate the specialties. But I mean, you don't need to be too worried about them really. It's kind of, you get kind of 1A and 1B will be the sort of submental and then submandibular, and then most of the things are sort of 2, 3, and 4. And then, like I say, if I was finding sort of 5s, usually it's lower 5. It's kind of where nodes shouldn't typically be, but it sometimes helps just to refer to those. So I tend to, when I do a scan, keep it simple. That's how it sort of tends to look. And this was the X-ray. There was nothing to see on chest X-ray. And this was the radiology scan. So again, a similar lesion to what I'd found, with some enhancing colour flow, which is not great. It's sort of a generalized pattern, which again is something we don't sort of wish to see. It makes us potentially suspicious of malignancy. And this was the child's MR. Same day. All of this happened within a couple of hours. And this is, as you can see, more tumor than baby, really, in many images. So not ideal. Again, multiple differentials were considered, but the concerns were about something worrying. And she got followed up, obviously, that day by the oncology team. And she had something which I was unaware of, an extra osseous Ewing sarcoma, which is very, very, very rare. And she commenced chemotherapy and then went on to be the UK's youngest ever proton beam therapy patient. We know about Ewing sarcoma, but extra osseous is even rarer than that. Again, she did very well after that, and we're now kind of a couple of years down the line, at least for her. So I'd put this into an article in which they just asked me to think about a kind of a bit of a like a protocol or an algorithm in your brain for concerning features for lymph nodes, which are all things that we're probably aware of, that we should have a kind of an oval 2x1 bean-shaped thing for a lymph node, not rounded, for a number of reasons. We should have a maintained echogenic hilum with kind of colour flow, with the vascularity in the hilum, but not displaced or peripheral or increased. You should be just about obtaining some flow, bringing again right the way up, a low velocity. It shouldn't be kind of very lit up. The wall should be smooth, not irregular, not too thickened. And local edema is obviously a worry, loss of hilum, and then echogenicity, increased calcification, that sort of thing is often a worry. So this was a few more neck lumps here, all a bit different. And with sort of the last patient in mind, I scanned this little 5-year-old boy, and he had a kind of very firm lump on the left side of the neck, probably kind of like between level 5 and level 3, kind of very firm, no redness, no heat, non-tender, no infective symptoms, nothing. And I put the probe on, and this was really unusual. So it definitely wasn't kind of expecting to see this. So we can see that we're probably within the sort of lower region of the sternomastoid. This to me looks like a regional lymph node. Probably on initial view doesn't look too bad. Probably often you find these are 2 lymph nodes side by side, but you can just see the separation there. Same, that's a very normal looking lymph node for me. But this I did not like. There's sort of central calcification with clean shadowing behind it, as you can see. Bit of reaction around it. Looks very irregular and heterogeneous. So I was not sure what we needed to do. So I got obviously a formal scan. More images. Again, calcification. You don't ever really want to see calcification. And so this is what I wrote at the time. Let's have a read. level 2 and 3 normal, yeah, and then the region kind of well-defined but heterogeneous with internal heterogeneity. I just said it does not resemble any kind of lymph node I'm familiar with, so we need to get a scan. Bloods were totally unexciting. And this was the radiology scan, very similar findings, yeah? So what we got back was really interesting. And I think, I work really closely with our radiologists. They're amazing. I could probably go around sometimes a few times a week. And, if I'm worried I've seen something, we sometimes scan it together, find a retrocecal appendix, or what was yesterday? What did I have yesterday? It's completely gone out of my mind. Oh yeah, kind of like the left kidney was really, really big and the right was really small, and possibly is enough there for pyelonephritis, but I think it's one of these ones that's tricky to diagnose definitively on ultrasound, if I'm honest, and not a lot of inflammatory stuff, but hematuria, didn't see a stone, and it was kind of right. There was a very small, apparently query scarred right kidney and a very large left kidney there were enough features probably to make a diagnosis of pyelonephritis. So often we'll go around, I'll have a discussion about what I've seen, if examination, bloods, etc. haven't been helpful, try and add a bit more information with POCUS. And our radiologists are amazing. But what happened in this scenario was a little bit interesting because the differential that came back from the scan was something unusual for a 5-year-old. It was queried, is this all kind of a subacute hematoma and a tear of a sternomastoid? Now, not doubting the expertise of the person who did the scan and what they saw on the scan, that clinical history didn't make any sense. It's not anything that I've seen in my time, in terms of a torn muscle without any trauma in this age group. So we had a bit of a think and decided to follow the child up. In time, I didn't think there was any benefit for antibiotics. And when the child returned, it actually progressed, this lesion. And this was the report, how it was described. And then it sort of broadens out to, could this be an infected hematoma? But then we've jumped from potentially a query muscle tear to, if not, could be a sarcoma, which I think it's just a bit unusual, isn't it? As the consultants looking after these patients, we'd want to try and get the diagnosis right and not have such a broad differential. So I think it just goes to show that sometimes, the opinions, you got to take everything into sort of context, and they may not always be absolutely black and white. So the child went to oncology, and I was in communication with the oncologist quite a lot because he's a very supportive kind of guy who said, yeah, thanks for sending that. It's very unusual. We don't really know what it is. 2 radiology scans haven't been able to confirm what it is. This was the 3rd radiology scan in the tertiary centre. And sort of saying the same, normalish lymph nodes in the region, but unusual lesion not able to characterize. So they got some cross-sectional imaging, which again was difficult to kind of characterize exactly what it was. Said it was at the sort of border of the anterior triangle and some unusual components within it, but described as inflammatory nodule, atypical infection. Does anybody have any thoughts about what the diagnosis could be? Haven't seen the scan, hearing all of that. Not colored.
Query TB is mycobacteria.
Wow, you almost as if you knew, right? So yeah, this was unusual. This was ATM, non-tuberculous mycobacterial lymphadenitis. And what happened was that they often, as you may be aware, they kind of can sometimes just leave these to see what they'll do, whether they'll self-discharge and drain, or sometimes it's a consideration of surgery. And that's what happened. It more or less discharged sort of in front of the ENT consultant 5 to 6 weeks later, quite a while. But a period of definitely unknown. This was all across maybe 2 weeks, so I was following up regularly. Looking back, this has got some really excellent hallmarks for ATM. So if you ever see this sort of internal calcification pattern, this is almost like the Google image of what you'd expect for that. So I think the key thing for me was that I've seen lots and lots of lymphadenitis. I'm happy with, abscess, definitely no abscess. Worrying node, or I suppose worrying non-lymph node. This was sort of within everything, and I couldn't work out, what the significance of this was relevant to the other lymph nodes. but this internal calcification is fairly classical. So I think that's something to kind of burn into your mind for the future. And
Dave, there was a question from the chat, and also those differentials were from the chat, not from me. Sorry.
right, okay, that was you. Okay.
So Vasilis asked, how do you think we should be explaining normal bloods to parents in the presence of findings in POCUS? I guess what I'm trying to ask is, what if we do not have POCUS skills and we reassure patients that all is fine on bloods and clinical exam unremarkable? How should we be approaching this without POCUS?
Yeah, I think from my perspective, I can only go off someone who uses POCUS for everything now, every day. I don't scan when I don't need to. I'll make that really clear. But I think, like a lot of the people on the call, I'd be lost without it for appendicitis or elbow injury or for neck lumps. So I think we've got to be aware that there's a paucity of pediatric trained radiologists in the country, certainly across Europe. I think from what you read, it's a similar pattern everywhere. You mentioned the word pediatric, and you might not be able to get someone to do that scan based on the word pediatric, even if they're 14 years old. So POCUS can hopefully fill that gap, deliver those improvements, but that comes with a big learning curve, progression, all of that. You have to be completely happy that you're working within your own clinical governance structure, your own remit. And obviously this is, 6, 7, 8 years for me trying to do this. So I think for me, POCUS adds that extra layer of information that a clinical exam can't. Hopefully each of these cases so far has demonstrated that to people so far, that with bloods or clinical exam alone, we just can't get any further. If that's 7 p.m. at night, you might not get the MR or the radiology, ultrasound, or the CT, or you might not justify a CT, because you might scan someone or you might examine someone, and POCUS can move you away from needing to do a CT. That's the real benefit of ultrasound and not needing to irradiate a child unnecessarily. So I think, obviously, you're here because you might want to learn more about POCUS and you might want to upskill. That's amazing. That takes time, but you're ultimately doing it for the benefit of the patient, are you, and their families. And we can hopefully make really quick decisions and get patients straight out of the PZD. For appendicitis now, that's what I'll do. I'll scan someone, very happy. You've got lots of clusters of lymph nodes. This is mesenteric adenitis, or this isn't appendicitis. You can be discharged home. And I think I'm just, to be honest, I'm not really a big blood sort of person, to be honest, as anyone who works with me knows. I don't like to fit that into my mindset of being reassured or not reassured. That doesn't make sense for me. I'm more, if I'm got concerns, then we're going to crack on and do some bloods because we've got concerns. Obviously, if you're thinking malignancy, it's worth checking bloods, of course. But I just think your exam and your investigations can only take you so far. For me, ultrasound adds a real extra bit of information. Does that answer your question, Vasilis? Spot on. Long answer. Always long answer for me, I'm afraid. Right. So, and if anyone disagrees with what I said, please just chip in. I'd be great to hear different people's perspective. So again, with all of these neck lumps in mind, this was a 10-month-old who came in late one night, about sort of 6, 8 months ago, 9 p.m. And he again had a sort of lump under the left ear. He was completely well, no fever, nothing else going on. The mass was felt fixed, but it wasn't hot or red. And this is what I found. So again, we're sort of next to the sternomastoid muscle. We've got some lymph nodes in different regions, but there are just some features that worried me a little bit about this. Again, I don't know if it was just its proximity to the muscle. There were certain sort of areas that I just thought I didn't like the look of. And some of the lymph nodes were quite small. So, for a cluster of really enlarged lymph nodes, I'm normally thinking clinical context of lymphadenitis, bit of infective symptoms, bit of temperature, bit of a tenderness or discomfort. This was none of that. This was cold, sort of fixed. The child was completely fine. So I didn't want to just call this lymphadenitis, to be honest, especially after what I'd seen. Bit of enhancing flow at times that I didn't really like the look of there. So yeah, just too heterogeneous. Although you can at times look back. Now I know what happened to this child. You can look back and see the individual lymph nodes. I didn't sort of like the sort of almost surrounding inflammatory bits, because it didn't fit with an inflammatory pattern. That was all. And again, I don't know if anyone would agree who does lots of neck scans. Thumb up if they agree that just looks not quite like your normal lymphadenitis. So this is what I've written, level 3, and this size, hard to tell if it's deep within the sternomastoid or deep within. I guess I was thinking back to this other case. I said there are a lot of lymph nodes around it, but quite enhancing flow. And again, normalish bloods, nothing too exciting. I know that was at the Y count. We didn't get it there. Normal bloods. So this was the radiology scan, which I think happened the next morning. Can't make a lot from that, but different sort of possibly different lymph nodes throughout. Maybe looks a bit more normal than mine did. And then this was their description: multiple lymph nodes and increased vascularity consistent with cervical lymphadenitis. So I thought that was interesting, given, you know, there was sort of very limited symptoms, no temperatures, no heat, no anything else. Looking back, I guess it is a collection of lymph nodes. You can see that. I just didn't want to be overconfident with this and kind of undercall it. So I think you don't want to create work for radiology, but equally, it's probably best not to definitely don't want to miss anything. And he came in, he got 7 days of antibiotics. I think his bloods stayed about the same. And to be honest, he was fine. So I guess that was just a strange case of non-inflammatory lymphadenitis. Okay, this girl was quite an interesting one. We got a call one tea time about 8 months ago to say that a girl was going to come across to see us with abnormal bloods. The GP had done some abnormal bloods. And just trying to see who's on the call, if anyone was involved. No, they're not. That's all right. So we've got story of some abnormal bloods. And these were her bloods, all right. So it's probably easier to work out what's normal versus what's abnormal. So we've got a bit of a renal hit going on or some kind of renal involvement. We've got really significant hypercalcemia, some raised inflammatory things. LDH is up a bit as well. And I think it was us who added on. Yeah, it was us who added on a PTH latterly, I think. I can't remember, or they may have done it. Yeah, and that was low. So again, I'm not a big kind of biochemical renal sort of person, but thoughts going through my head were as follows. So is this parathyroid related? Is this renal related? Is this medicine related? Or is this something malignant? So obviously we know, you know, with things like tumor lysis, it's hypocalcemia as a result of the kind of binding of phosphate, but can also be, you know, can also give hypercalcemia due to the kind of paraneoplastic involvement. We had this really interesting case of scabies recently in the department where it was just an advanced case of scabies and hypercalcemia, and there's a link with the two, apparently, and this child was thought to have malignancy but didn't, and it's something to do with the cross reaction of the kind of macrophages, and there's a receptor that can cause the calcium to go through the roof. So we'd had lots of things recently, but we were quite kind of worried when we saw the blood results. So on inquiry with this girl, we'd noted that she'd had lower energy and some tiredness for a few months, and that there'd been some things going on in the background, that there were some concerns as to whether this was a bit of overlay and some mental health. When we saw her, she did look pale, unfortunately. And I examined her and I said hello, and I said, what's going on? She said she has some pain in the back. She's struggling to sleep, and she also had some pain in the shoulder, and she just pointed to her right shoulder, just like that. So again, this was getting on for sort of 7 p.m. We needed to understand what we needed to do. So I put the probe on, and I guess if I'm going to do an abdominal scan, I'll always start right upper quadrant. Had a look, and this is the kind of look closely element of the talk. So I don't know if anyone can make anything out in this kidney image that's of a worry, or in and around the kidney. And I continued with the scan in the upper quadrants, sort of liver, kidney, and throughout. Can anybody describe what the abnormality is we're seeing, or what would concern them? Someone just wrote, I think, tumor. I think that's a new talk, a new comment, sorry. Yeah, so not great, really. So seeing all of these lesions.
Jessica says cystic mass in the lower pole.
Yeah, so again, it's probably easier to say what's what's normal, isn't it really? But yeah, this thing caught my eye here. You can see on some hand, you think, is this some calyceal dilatation? Although there's no renal pelvis dilatation. But yeah, there were just some other bits that kind of caught my eye straight away. And then unfortunately, it was the same scenario throughout the kind of liver and kidney. So all of these things are really absolutely classical of metastatic lesions, kind of surrounding hyperechoic halo with the central echogenic region, some of them quite massive, to be honest, unfortunately. And I asked her where she saw for her arm, and she just pointed to her humeral head, and I put the probe on, and this is what I saw. So this is in long, and you can obviously see the overlying deltoid muscle. You can see the kind of degradation of the bony surface here, and probably new bony growth. Same here in transverse, coming across up the arm. And this is kind of oblique in between the two. This is probably up near the physis, and this is the kind of humeral shaft and head, neck. See, obviously, it's kind of what you'd describe as, I guess, as a fracture with really significant secondary soft tissue reaction, which is very, very heterogeneous, very not nice to see. That's a real worry. I mean, you'd probably look at that in context alone without anything and say that's a malignancy, just because of how it looks. There's very little else that I think would fit with that pattern overall. So we did a CT, and again, you look at this and you think, all right, so this is, I'm not great at CT. I mean, this is easy, but you look and you think, okay, we're in the lungs, and you think, is this an organ? And then you go, no, because we're still in the mediastinum. So none of this should be here. So this is a huge mediastinal mass. And then huge degrees of metastatic involvement throughout the kind of abdominal region. This is the humerus. Again, just looks really unusual and abnormal. And this was the CT scan that we got. Again, this was a case of just taking the ultrasound machine round to show our radiologists. This was every time, it's always late in the evening, like 7 p.m. People are leaving to go home. And I kind of more or less begged the radiologist to stay and to do the CT scan and to report it for me because of what I'd shown him on the radiology, on the ultrasound. I just said, these are all obviously look like Mets, and this girl looks not great. So thankfully, you kindly stayed around, give us the report. Large malignant lung mass infiltrating mediastinum with Mets throughout. So we spoke to the oncology team there and got her across. And this is the girl's PET scan, which is so fairly devastating, really, in terms of the level of involvement. And I'd never seen one to this extent, certainly when I've ever worked up a patient or seen any PET scans. However, amazingly, a year on, she was given the all clear. Amazingly, so she'd had chemotherapy and I think some targeted radiotherapy, but not fully sure exactly what she'd had. But yeah, amazing, absolutely amazing story. Young people are incredible. Except, you look at this scan and I still don't know how you I don't know what happened with the metastatic. I've emailed the oncology consultant to give me a bit of an update about how you treat this and how can you cure this. And I'm just waiting to hear back. But they're doing great, which is amazing. Okay, last couple. What time are we on? Yeah, I've got time. So this was an 11-year-old boy. One of my colleagues who was on the call was involved with picking all of this up. And it was just a kind of a fairly insidious sort of low-level story of an 11-year-old boy previously totally fit and well with a bit of cough, which was described as productive. I think this wasn't in the winter because this was a little while back, but not a worrying story. However, there's some concern about possible weight loss, about the child just looking thinner. So the team in the afternoon saw him. Those were his numbers, not too concerning at all, but it was noted to have some quiet breath sounds on the left side of his chest compared to right. So the team did an X-ray, and this is what they found. Sort of hands up, would you think concerning? Hands up, or would anyone think this is a sort of a more benign problem, for example? I would certainly say worrying looking at that. However, just again to illustrate that we work as a team and not everything can be taken absolutely as read. Just because we're not radiologists. If we do a scan, I don't think you know, like I say, work phenomenally well with our radiologists, but sometimes the descriptions that are given won't always be sort of exactly right, and we need a bit more thought, because this was the description about, could this be inhalation of a foreign body, which I thought was a little bit of a strange one. It didn't sort of look like that to me. So as my colleague was having a bit of a chat with the family and making plans to arrange some formal imaging, we took the opportunity to have a look at him, because he didn't sort of look, he didn't look kind of great. And these were the images we saw. We want to obviously look at the lungs, and here we can see we've got the left lower region of the lung above the spleen. We've got a nice collapsed lung there with a fusion, sort of jellyfish tail flapping around. But interestingly, you see the lung in context, it looks quite uniform. So it doesn't look like an infected process, lots of consolidation, ragged pleura. It almost just looks like the lungs collapsed for some reason. And then in this view, can anyone jump in and describe the findings, what we're seeing here with the curvilinear probe? Anyone feeling brave?
Where is that? Is that in the same region?
Yeah, that's, one sec, is it left or right? Yeah, that's left, so that's curvy left, yeah. So just to point out, there's a few things going on, isn't there? So we've got some black, we've got a lung, so we've got an effusion, but what's this? So in addition to a pleural effusion, I was thinking, wow, it looks like we've got a pericardial effusion. Wasn't certain on that view, obviously. However, oh yeah, lung first. So probe on, and again, I was talking about anything heterogeneous in the lung. This was, you know, about as high level as concern as I could possibly get looking at this. So this is a rib and a rib, what should be a rib shadow. Normally we'd see a pleural line and some movement, some A lines, maybe a few B lines, but the lung had no lung. This was tissue in the lung, and it's extremely kind of heterogeneous calcification, that sort of thing. So I knew this was really worrying. And then this is just an image to show you that on one side of the chest, which as you can see there, so this is me moving from left to right. So we can see one totally normal lung on the right there, and then we can see, so normal, but then it doesn't show it that great. But I was trying to get the idea of this at the start of the clip. I'll pause it. Don't think I can. You've got kind of no A lines, no pleura, just tissue, just from here to here. So whereas you might think at the start of that clip, am I seeing a bit of liver? That's actually us seeing this big mass on the left side moving over to the right. And then just to confirm, this was the echo. Sorry, did someone want to ask something? No, it's a bit noisy. So this is the echo image with, again, this circumferential pericardial effusion, quite large, but not showing any obvious signs of tamponade physiology based on this. So this was the big mediastinal mass on CT, described as borderline enlargement spleen, yeah, large mass with some necrotic regions, some collapse of the lung, and pericardial effusion. Okay, nearly done. So we're talking about different lesions, unusual lesions, and things you might find. Not everything is malignancy, as we've seen, but this one was also quite an interesting first for me. So this was a 7-year-old girl who was an ex-preterm who had obstructive hydrocephalus secondary to a bleed and had a VP shunt inserted as a neonate. She'd had different revisions for different things, but interestingly, I think mainly abdominal concern rather than kind of concerns about blockage and about pressure. So when I saw this was about 4 weeks ago, on a Saturday, and I came on for my later shift as a consultant in the daytime on the morning, and this girl had a big swollen abdomen, but didn't look too sort of poorly. She had a gastrostomy, and her grandfather changed the Mickey balloon, and you know, kind of was happy doing that. But this swelling coincided with changing the balloon 5 days ago. Feeds were going through and were being tolerated fine without any vomiting, but the tummy was quite big. And interestingly, there were no aspirates on gastrostomy. So my colleague asked me to have a little look and said, you know, we're not going to be able to get any sort of a scan. What do you think we should do? And, you know, this is a really good example where POCUS can add so much detail relative to just examining. And you know, you don't want to CT every single child. It didn't look like obvious obstruction. It just looked like we needed to figure out what was going on. So tummy was big. And this is what I found in the tummy. Anybody want to hazard a guess as to what it is that we're seeing? Even in simple terms, it's fine.
That gastrostomy within a distended stomach.
Nah, closed. So the gastrostomy is definitely something I wanted to be aware of, especially with that story. But I think, you know, gastrostomy, the sort of balloon bit would be the bit internal. Everything else would just be a bit of a tubing coming out and would be quite short. This is actually quite long, isn't it? Look, this is, I mean, you're right, a primary gastrostomy might be, but I don't think this kind of looks typically like what I'd see for a stomach. And this is long. This, what we're seeing, this is like a long piece of tubing. So we're seeing a big fluid collection where it shouldn't be there. It's obscuring all of the other anatomy centrally and kind of not really making out much right upper quadrant, etc. We're seeing this strange septation, but we're definitely seeing a piece of artifact within it, and we are. What we're seeing is the tip of the VP shunt here. It's a VP shunt, and this is a big thing called a CSF pseudocyst. So it's this big thing where a cyst forms around the tip of the shunt. And these are quite rare lesions, although you know they can occur with VP shunts over time. It can be associated following infection. And I was able to have another look and see the gastrostomy balloon in situ in a separate place, and also see the tubing running through in the normal position. So I just put the probe on above where the entrance was and kind of try to scan up and down to see what was sort of nearby. And you can see this interesting hallmark of a bit of, you know, it doesn't look organic. It looks like a piece of tubing, not much reverberation from the plastic, but I was happy that was the tubing. So that seemed to be in the right place. But yeah, these big. One. Oh, did you want to ask something? No. Right. Keep down the chat. Yes, shunt related, someone said, definitely. So so this was the CT, which just obviously for sorry, we didn't do this the same afternoon. We actually transferred across the tertiary surgical centre, but they did it for surgical planning the following day. I was quite sort of happy actually with what I was seeing, and spoke to a consultant colleague who I know quite well, who is a paediatric surgeon who's also learning. We'll be teaching him on the postgraduate ultrasound course tomorrow actually. So someone who was aware of this case and also aware that we could scan and add a bit of value. And I think she'd had previous problems sort of similar with fluid collections. So they got a CT the following day. You can see the tip of the VP shunt and this big collection that goes from sort of up top to bottom. And yeah, this is what she had, this loculated collection, and she had the shunt revised. Quite interesting. And the last one, if people need to leave, obviously they can. This was a 5-week-old girl who came in. She looked quite well. She had a lump to her neck, too many neck lumps in my department. But she was a term little one, had an instrumental delivery. And this is what we saw. So would anyone be worried by this, or would people feel happy with what they're seeing here based on these images? Anyone who does any neck scanning? Or any differentials anyone would like to throw out?
Khaled asked, where are you? Where is it?
Sorry, so lower aspect of the neck, kind of like sort of level 3, possibly a bit more posterior. So between level 3 and level 5. So normal thing would think with neck lump in little one, it could be one of our nasty tumors that we've already had in our department. Whoops. But really, we're thinking, you know, a little 5-weeker with a lump who's well with an instrumental delivery is we might be thinking like sternomastoid tumor, so fibromatosis coli, so like a little lump. And I was fairly happy with the sort of like blood flow pattern there. I thought, okay, I'm obviously seeing something centrally, but I'd never seen this. I've never seen this problem look exactly like this, which is what I'd seen. So this is what I'd drawn, and this is what I'd written. Bit heterogeneous. No echogenic hilum, so I don't think it's a lymph node, no cystic components, nothing enlarged. And then the added bit here, difficult to see on scan if this structure is related to the sternomastoid muscle. I'm unable to demonstrate the normal connection to the contiguous muscle fibers. So this problem, we're obviously talking about a kind of the muscle belly having like a fusiform dilatation where we see the fibers run in, but based on where it was near a clavicle and up, I couldn't quite get the fibers to run in. And the thing that was worrying me was this funny little central bit here, which I'd never seen before for this problem. Other than that, it looked really uniform. So I felt it did kind of look quite uniform, but I wasn't 100% certain and didn't want to just sort of jump in and make a call. And then I presented this to a different group. Antonio, I don't know if you're still on the call, but I don't know if you remember when I presented to PPEC with this thing. And a few people also, well, I think everyone also thought the same. They weren't too sure that it was definitely just a fibromatosis, which is obviously totally fine and benign. And then I looked into it a bit, and oh yeah, she did. This was we brought her back just to be absolutely certain for an MRI because the radiologist wasn't certain either. They did an ultrasound, sorry. I don't know if it was a pediatric radiologist, but they decided to go ahead with MRI. This was after I'd stopped being involved with the care. But again, you can see there it looks quite uniform. The neck's pulled to one side, so you think, yeah, it probably would be just a sternomastoid tumor. And then I looked into it a little bit and realized that this separation of these two bits of the muscle with this membrane in the middle, which I've seen loads of these, I've maybe seen kind of 10 or 12 and just diagnose them there and then and send the child away. But I'd never seen it with this strange membrane, and I just wondered, am I seeing something else? And actually, it was so low down on the clavicle here that whereas normally you might get them in the muscle belly there with just the dilatation, it comes out. If you split it between the sternal and the clavicular heads there and there, you get this funny separation. And this was eventually her scan when it was plotted, and a pediatric radiologist reviewed it, and we saw nicely the muscle fibers coming in and coming out, which makes it just a simple sternomastoid tumor. Call it a tumor, but it's not really, I guess, a typical tumor. So yeah, so that was an interesting learning point for me that you can get these dual elements to it if it's very low down at the origin. So that was good learning. There's the paper that talks about it. So there we go. Those are all the cases I've got. Hopefully I've not ran over too much. Hope some of those were useful for you guys for seeing new things or seeing how POCUS can be useful. If anyone has anything they want to ask, I'm happy to answer. Or any comments?
There's just some generic comments of.
I can see.
You can have a look. But...
Yeah, cool, good. Some happy endings. Great. Okay, hope everyone's found that exciting, as exciting as me. Thanks for coming along. And if you have any other colleagues who might be interested in coming, let them know. We're probably going to take a break for December, just because between Nigel and I, we couldn't really make the dates work. I think we're busy on all 4 of the Wednesdays, and the last one is Christmas Eve. So unless anyone wants to meet Christmas Eve, I think we're probably going to have a break. And we'll come back in January. If anyone would like to talk at this meeting, or anyone knows anyone who's got a lot to offer for ultrasound, could just be simple cases, doesn't need to be anything exciting. If anyone would want to go and have a little look at some literature and look into a little topic, that would be amazing. You could come and present at this meeting. But yeah, good to